So, good evening, all the aspirants present here. The topic for today is maternal medicine, and it will be taken by the speaker, the faculty, Dr. Varun Pushkarna, sir. So, over to you. You may start.
Thank you, Sana. So, we had covered most of the topics in the last class, and these are the remaining ones. So, we will be discussing whatever was left in the last class. So, very important topic is RH isoimmunization and the role of immune globulin. So, RH incompatibility, when does it occur? So that happens when a Rh negative mother is carrying an Rh positive fetus. So that means the Rh negative mother, her blood has never seen an Rh antigen. So when the fetus is inside the mother's womb, what happens is at the time of delivery, when the blood of the fetus comes in contact with the blood of mother, that is when the mother's blood gets sensitized to the Rh antigen of the fetus. So this is problematic. Why? Because now the mother will prepare antibodies against that Rh antigen. So the next time, whenever she conceives, the baby, if it is Rh positive, will be killed inside the womb, inside the uterus by the antibodies which can move from the placental circulation. So we all know that the antibodies that are produced at the first exposure are IgM type, but later on they will get converted into IgG type, which are transplacentally movable. So that is the problem. So the fetal red blood cells, when they enter into the maternal circulation, they lead to production of anti-D antibodies. This is very important, which then cross the placenta in subsequent pregnancies. So I'm very categorically saying that it doesn't happen in the first pregnancy, it will happen in the subsequent pregnancies. And they will cause hemolysis of the newborn. Okay. So the prevention, how can you prevent? You can prevent it by giving ready-made immunoglobulin IG. What will it do? There is something known as prozone phenomena. Can anyone tell me what is a prozone phenomena? Can anyone tell me? So the prozone phenomena is that whenever there is an amount of antigen is overwhelmed by the amount of antibody attaching to the antigen, this is the antigen. So what you see here is that there are so many antibodies that they have completely covered the antigen, and the antigen is not available for being exposed to the maternal blood to produce the antibodies. So this is very important that you give immunoglobulin so much that it neutralizes the fetal Rh positive RBCs before the sensitization occurs. So you have to understand what is the timing of the Rh immunoglobulin. Routine antepartum, it is 28 weeks gestation, 300 microgram IM. It will cover 30 ml of fetal whole blood or 15 ml of RBCs. As I am telling you that the concept is based on prozone phenomena. Hence, you have to see that the amount of antibodies that you are giving, they are matched to the blood of the fetus or the RBCs of the fetus. Within 72 hours of delivery of an Rh positive infant, the mother gets another shot of 300 micrograms intramuscular. Potential feto-maternal hemorrhage, that is miscarriage, abortion, ectopic, or amniocentesis, chorionic villus sampling, trauma, all these things, they require 50 micrograms of dose if it is below 12 weeks, or again 300 microgram of dose. So mota mota, you have to remember that the dose of the Rh immunoglobulin is 300 micrograms, if anything after 12 weeks of pregnancy. So what are the key laboratory tests? You send indirect Coombs test, indirect antiglobulin test that detects the maternal antibodies. It's a screening test. Direct Coombs test detects antibodies attached to the fetal or neonatal RBCs. Then there is a KB test or Kleher-Betke test or flow cytometry, which quantifies how much fetal RBC in maternal blood are there to determine the need for any additional. So you remember 300 microgram is the dose that we are to give. But if KBT tells you that it is more than 30 ml of uh, the fetus, the fetal blood, then you have to give more dose. So, if the exposure has already occurred, now sometimes when the pregnancies are unattended, the patients they come directly. So then the immunoglobulin has no role. Then you have to manage the pregnancy as a high risk pregnancy because you don't even know if the patient has had a miscarriage earlier in her earlier pregnancy. So you don't know because they are unattended people. So then you have to send the antibody titer. So if it is more than 1 is to 1 to 1 is to 16, indicates high risk of hemolytic disease of the newborn. Or serial middle cerebral artery Doppler for fetal anemia. Intrauterine transfusion can be done if severe anemia is there. These are things which are possible these days. Or if the fetus is mature enough, then you can attempt early delivery. Now, the questions that can come from this: a 26-year-old second gravida, one primary woman with blood group ORH negative presents at 28 weeks for routine antenatal visit. Her antibody screen indirect Coombs test is negative. Her previous delivery was an RH positive infant and she received appropriate postpartum immunoglobulin. Which of the following is the most appropriate management at this point? She is 28 weeks. They did an indirect Coombs test which sensitizes the presence of antibodies in the mother. So it is negative. No treatment is needed until delivery. Administer 50 microgram intramuscular now. Administer 300 microgram intramuscular now. Administer RHIG only after the delivery of infant is RH positive. Perform the Kleher-Betke test and give additional dose of RHIG based on the result. So anyone who can suggest me an answer here?
So we will go with administration of RH immunoglobulin 300 microgram now.
So at this time, you have to give full dose of RH immunoglobulin because the mother is indirect Coombs test is negative. That means she doesn't even have antibodies in her body. So you don't want subsequent pregnancy to get the same insult. Are you getting me? This is protecting this pregnancy and the subsequent. Let us suppose if she gets pregnant for the third time. So this time around, most likely she doesn't have any antibodies in her, but that doesn't mean that you will not go ahead with the prophylaxis. So you will do your bit. And the RH negative woman, so the answer is giving 300 microgram now, should receive prophylactic RHIG at 28 weeks and within 72 hours postpartum. So 300 microgram, this question can come. 300 microgram protects against 30 ml of fetal whole blood. Exactly correct answer. Now is LO immunization and management of hemolytic disease of the newborn. A 30-year-old G2P1 woman at 28 weeks is R negative. Her antibody screen is positive. So her indirect, that is indirect Coombs test is positive with a titer of 1 is to 64. Her previous child had neonatal jaundice requiring exchange transfusion. Ultrasound shows hydrops fetalis and increased MCA Doppler velocity. That means the fetus has anemia. So, which of the following is the next best step? So, she's just 28 weeks. Already, the fetal uh, already the fetal hemolysis has begun, what we can make out from the situation. So, will giving RHIG now help the patient?
No, sir.
So the so LO immunization has already occurred. So that means now it will not help. It has already occurred. The purpose of RH, this NTD, was not to let the exposure happen. Now the exposure has happened. The lady already has antibodies. So if you are going to give more antibodies, it is not going to help. She already has enough. So now administering RHIG at this moment is not advisable, not recommended. It is not going to help. Perform amniocentesis to measure bilirubin levels. This will not help in any way. Arrange for intrauterine transfusion with O negative, antigen negative blood. Absolutely correct. So we see that the MCA Doppler velocity is increased, indicating anemia. So we would arrange for intrauterine fetal transfusion. So we would go for blood transfusion, but with the O negative, antigen negative blood. Giving corticosteroids, planning early delivery is not recommended. No mention of steroids anywhere in the process. So this option is absurd. Repeating antibody titer levels every 4 weeks again is not going to help. So we remember that from our lecture today, 1 is to 16 and above. Here the titer is 1 is to 64. It is a very high titer. So there is no fun of repeating antibody titer every 4 weeks. By that time, the child would have been killed by the mothers.